Nope. Yes? Okay, good. Hi, my name is Ravi Namana, and I'm one of the executive directors here at CITRIS. I'm in charge of services and healthcare. And welcome to the CITRIS Research Exchange. We have a very wonderful session for you today. But first, let me go through a few administrative details. First, we'd like to thank Infineon for sponsoring this research exchange and for the lunch that you're all enjoying. So thank you very much. This session will also be webcast to our CITRIS partner campuses. So we have UC Santa Cruz, Merced, and Davis online. And we'll also take some questions from them. Yvette will coordinate that in the Q&A session as we end. And next week is our very last research exchange of the semester. So it's the last one. Please note that. And on Friday, December the 7th at 4 p.m., we're hosting the CITRIS Holiday Gala, and it'll be in the lobby of the Hearst Mining Building. It's a very beautiful lobby. We hope you can all come. So today, it's a topic that's very near and dear to my heart. It's a topic of telemedicine. And our speaker, Jim Marson, is a physician. He's an MD, and he holds a master's in public health. He's a pediatric intensivist, or a specialist in pediatric critical care, and he directs the UC Davis Children's Hospital Pediatric Telemedicine Program and the UC Davis Critical Care Transport Team. He's a member of the Center for Health Services Research in Primary Care and the Graduate Group on Epidemiology. His research involves the use of telemedicine in emergency departments and the intensive care unit, and assessing and improving outcomes and the quality of care provided to acutely ill and injured children in Northern California. So without any ado, Jim, thank you very much.
Here. I am a pinch hitter. The director of the telemedicine program at UC Davis, Dr. Tom Nesbitt, wasn't able to make it, so I hope I can follow well in his footsteps. So I presume that there's not a lot of clinicians in the audience here or being broadcast, so I'm going to talk in general terms about the way that we use telemedicine at UC Davis, and the way I envision it will be used transform the way that we deliver health care in the United States and internationally. I always start with the slide that I still don't have any financial relationships with any private companies or anything like that, or stock, unfortunately, but I'll be available after the presentation if there's any interest. So what is telemedicine? Telemedicine, the definition of it is interactive health care over distance using information or telecommunications technology. And there's different people categorize it in different broad categories. I just put it into two, which is the one live interactive, which is really kind of just video conferencing so that I can see and hear somebody on one end and they can hear and see me on the other end. And the other general type is called store and forward, or asynchronous, where data is collected on a patient, either video or EKG or something like that, or a picture of a skin lesion transmitted, and then the specialist on the other end can review that and get an answer back to them. So asynchronous. And it does not typically include telephone or fax telemedicine. So in the bottom right is the medical director of our telemedicine program, Dr. Javed Siddiqui. He's doing a telemedicine consultation there in one of our consultation suites. So he can sit in there for a morning or an afternoon clinic and see patients all over Northern California using this technology. And this is another one where they're doing an echo on the heart, and the doctor can review and see the images of the heart. So the basic premise about telemedicine, or why this technology or way of delivering healthcare is of interest or of utility, is that in medicine, specialist teams are regionalized. It makes a lot of sense because specialists have to work with other specialists. They want to be located in big cities. That's where the populations are. And we know that regionalization in healthcare generally improves efficiency and increases quality. However, just that setup, the way that it's set up, creates disparities, because now between here and the next big city, going north, for example, up in Redding, there's no, the pediatric intensive care unit that I work in at UC Davis in Sacramento, the one north of us is in Portland, Oregon. So all the kids that are between here and Portland don't have access to critical care, pediatric critical care physicians, but it is what it is. So the way that telemedicine can come in here is that it can allow these regionalized services to be available on every street corner, if that makes sense. So that's kind of the premise under which it works. It is becoming really the standard of care for a lot of the way that we deliver health care. It's exponentially increasing the use of it. Now it's available in all 50 states. There is improved quality and lower costs of the equipment. So the video conferencing equipment and all of the gadgets that we're using are better quality and lower cost as time goes on. There's improved quality and cost of telecommunications. And there's increased opportunity for funding, grant funding, as well as healthcare funding, like from the federal CMS or from the state DHS, Department of Health Services. And of course, the federal government has their fingers, or whatever, if you want to say fingers or pulse or whatever. There's something called the Office for the Advancement of Telehealth in the federal government that helps to monitor telemedicine on a national level. There's also changes in reimbursement, which is important in medicine, so that now doctors that are seeing patients over a distance are reimbursed for that. And while we argue that the legislation is often behind, it does come around so that it's appropriately monitored. A big thing now is home telemedicine, so home visits, patients that are seen at home using this technology, hopefully within the next couple of years, that will also be reimbursable. Also, there's getting over the early adopter hump because physicians, like everything else, are using more PDAs and Palm Pilots and stuff like that. So the younger generation typically is more accepting of this type of technology in the delivery of health care. Post 9/11 and Katrina, terrorism, natural disasters, the federal government's very interested in it. And again, these data just reflect at the bottom that the use of telemedicine is increasing every year. From the healthcare standpoint, there's also global benefits of the use of telemedicine. I mentioned the reduction in distance barriers of access. There's a lot of data to demonstrate clearly that people, adults and children that live in rural areas have lower healthcare markers than those that live in urban and suburban areas. And probably some of these disparities in health outcomes are attributable to access to care. And so by addressing this access, hopefully we can help address the disparities in health outcomes. There's also improvements in quality of care. I'm not sure how many of you see subspecialists or something like that, where you see your primary care and then go see the subspecialist and then no one knows what the hell they're doing, or they don't communicate back, or we try and send them a letter but we don't have their address. But the telemedicine, when you're video conferencing with the primary care provider and the subspecialist, they're all in the room at the same time. So everyone knows what you're talking about. The primary care provider knows why the specialist is changing the medicine. And the primary care provider learns. There's increased confidence for the patient in their primary care provider. So there's education going both ways. There's a lot of data to show that for a lot of subspecialty consultations, the patients are happier this way, and the remote isolated providers are happier with this technology. You can also argue that this technology will reduce overall healthcare costs. It depends upon, you can focus in on the telecommunications and the equipment, but if you talk about lost dollars for somebody having to take off work to drive to the office, or preventing a hospitalization by getting an earlier intervention by seeing them at home at a remote clinic, then you could argue that it also decreases overall healthcare costs. It has been shown to increase local perception of quality care, so remote hospitals that otherwise people would drive by to the major medical centers, they have more confidence in their local healthcare systems, which is an important thing for our model of healthcare. And in many ways, this technology can help increase the efficiency of tertiary centers. So specialists can screen things that they don't have to see the patient in person for preoperatively. Pediatrics, again, that's my world, and so forgive me for all of the pediatric examples, but our pediatric gastroenterologist, number one referral for pediatric gastroenterologist is constipation in a child. And now he tries to see all of those over telemedicine, and if he anticipates a child needs endoscopy or some procedure, and those are the kids that he will bring to his clinic and pre-op them in the same visit. So how big is telemedicine? UC Davis is definitely a national leader and an international leader in telemedicine. It has one of the largest networks in the world. And this is where all of the places that we're hooked up, more than 85 currently, for patient care as well as ongoing education, CME education. And that's going to get bigger. The state of California has been very supportive of this concept of telemedicine, again, trying to address disparities in care and increasing access to the patients, the population of California. And then the FCC just, was it last week, I think, just devoted $417 million to 42 states and 3 U.S. territories to increase broadband specifically for health care. California, UC Davis is the PI on the proposal that we sent in, but it's all of the UCs, it's the whole state, and we're going to be connecting in the next 3 years. These are all rural hospitals here, the dots on the map, but 319 hospitals now in the state of California, the rural ones, will be getting broadband specifically for telemedicine or telehealth care. So this is on the federal level, but the state has also been investing a lot into this technology. Where can it be used and where is it most often used? The number one application of what we call telemedicine here is for outpatient specialty consultation. So if you need to see a cardiologist and you live in Plumas, you don't have to drive to Sacramento or San Francisco or whatever, but you can go to your local doctor's office and see the cardiologist over video conferencing. Number one application of it. But it can also be used anywhere healthcare is provided. This technology can be used. And emergency medical services, from scenes, from disasters. Katrina, we had our system up and available for that, so that these systems can be deployed to triage patients during transports, long transports, in ambulances and helicopters in the emergency department. Also, inpatient specialty consultations. So you're admitted to Mercy Reading Medical Center, 160 miles north of us here, and they don't have a pediatric dermatologist. Well, currently what they do is they discharge the kid and say follow up in 6 months because that's when our next available appointment is, or they'll transfer the patient. But now our specialist should be able to see that patient up in that hospital also. It's done for procedure and study interpretation, including EEGs, echocardiographies, or ultrasounds, fetal ultrasounds. It's all used for that. It's used for intensive care unit consultations or monitoring, and that's a booming business. Also, surgical and trauma consultations where patients, it's not a trauma center, but a patient comes in and a trauma surgeon is able to quickly assess patients. But other applications, it's used at home health, as I mentioned. It's a booming business. Physician, nurse, healthcare provider education. It's used in chronic care facilities. You prevent the ER run to the emergency department where the docs can see them out there. Daycare centers. There's a program in New York where sick children can see a pediatrician so that when the mother or the father comes to pick up their kid, that not only has their child been seen by a physician, but the prescription is there for them to pick up and take home their child. So there's lost days at work. Connecting families of hospitalized children or adults. Hospice care, international telemedicine. I'm part of a couple of projects with international telemedicine too. So really, and I'm sure I'm leaving things out, anywhere healthcare is delivered, this technology can be used. So I'm going to touch a little bit on some of those applications, and first I'm going to talk quickly about outpatient telemedicine. There's lots of studies to demonstrate that over video conferencing, healthcare outcomes, as well as we can measure them, are as good as they are in person. But as you might imagine, they might be better in some areas of subspecialty care than others. The big three are dermatology. Dermatologists, all they care about is looking at this, the skin or whatever. They don't care about other things like your social history. But we can get those images across with a general exam camera. Endocrinology, that's number one is like diabetes or thyroid disease. They can review a lot of the laboratories, and they can do that over video conferencing. Psychiatry, it's a big use for telemedicine, and it's very interesting because oftentimes it's higher satisfaction with patients because they'd rather not walk into this psychiatrist's office, but they can go into their regular office and see the psychiatrist from their general practitioner's office. So they don't, I don't know, maybe it's not so comfortable to sit on a couch and have to talk directly to a psychiatrist. but I can imagine. And then there's other specialties that may not work so well. Orthopedics, you know, they need to see x-rays, they need to feel the joints, rheumatology, some surgical consultations. But it is quite idiosyncratic because there are very successful rheumatologic telemedicine programs, and a lot of it can depend upon the hospital, the doctors, and what they're willing to take on. So this is, So I know that you guys are a bunch of real scientists, and this is embarrassing for me because when my kid came down and said, "Well, Daddy, what are you doing?" I'm like, "I'm working on a talk now. Get to bed." And my kid's like, "Daddy, what are you doing?" I'm like, "Get to bed, or else you're gonna be in trouble." "Daddy, what are you doing?" So I'm like, "Okay, I'm working on a talk that I'm gonna have to give." "What's a talk?" I'm like, "Okay, it's when I go up and talk in front of people." And he goes, "Oh, so you're working on show and tell?" And I'm like, "Yes." That's exact. And so you're scientists, and I'm sorry, but this is a lot of the show and tell what I have for you. So this is, well, and we have audio on this. It's a little bit, but it shows what an outpatient consultation would work. Do you have video or audio on this?
Like this.
Oh, there you go. See, and it has the silly music. And
To live in rural communities like this. But when there are special medical needs to consider, living in small towns can mean big drives.
Well, we live in a remarkable state in which patients come to me from southern Oregon, from middle Nevada, from the center of California all the way to the coast. People can travel to see us 7 hours on some occasion, one way.
Dr. Dennis Stein is a pediatric endocrinologist at the UC Davis Medical Center. He knows the difficulties families face when traveling long distances to receive high-quality, specialized care for diseases like diabetes.
Last time we saw her, hemoglobin A1C was 10.
But all that's changing thanks to the expanding world of telemedicine. Now, coordinated care from one home base or a medical home is as easy as making a phone call.
How can we bring the medical home to some of the smaller towns a few hours away from here that have a population that isn't conducive to setting up all these specialists on their own site? Well, we can use telemedicine, and we can use all the expertise of the environment that we have here at the medical center and bring it to the smaller centers and provide a medical home for the child in the smaller towns. And I see 278 this morning.
In this telemedicine consult, the specialist, Dr. Stein, is in Sacramento.
Do we have any noontime values?
While 15-year-old Sarah, her mother, and her primary care doctor are 90 miles away in Oroville. Sarah's diabetes has been out of control
all right,
for some
I'm
time.
skip it from here, just because, whatever. It's like, you get the point there. Plus, we can't afford flat-screen monitors at UC Davis, and it's embarrassing. The other thing about the financial impact, there's been lots of studies to demonstrate. So why, insurance companies are like, why do we want to do this? Hospitals, why do we want to do it? But a lot of times there's a good financial model behind this. The remote site, when they have patients stay in their local community, they're able to collect the revenue from the ancillary visits. There's something called a facility fee that you're able to collect when a patient comes in. And there's also laboratory work, x-rays, CAT scans. So like on that little girl with all of those labs, all those labs are done at that remote hospital, and they get a financial gain by doing those labs as opposed to them driving a couple hours at UC Davis paying $24 to park their car and all of that. So now we can go to these hospitals and say, look, we'll be able to do this. And it will cost you such and such, but it'll be a financial benefit for you. So the financial model of that works. So this is not a huge application of telemedicine in the emergency department, but it's what I do research in, so you have to listen to it pretty much, I guess, just like every other lecture that comes up here. But we do know that rural hospitals, in particular with children, are less prepared with regards to equipment and training. They're less likely to have access to pediatricians and pediatric subspecialists. There's other data out there in the pediatric world that show that 40% of emergency departments lack access to 24/7 pediatricians. And I'm not sure if anybody's familiar with the 3-book series out from the Institute of Medicine on the future of emergency care. There's one book on children called Growing Pains, where it's in a way disgraceful. While children make up 27% of all emergency department visits, only 6% of the EDs in the U.S. have the necessary supplies for all the pediatric emergencies. And because a quarter of the population lives in rural communities, 50% of all these EDs in the U.S. see less than 10 children per day. So my specialty, what my model is to try and address this disparity by putting telemedicine in a remote emergency department so they can have access to whatever pediatric subspecialist that they would need. This is Calusa, which I think is a 3 or 4 bed emergency department. And all we have here is a wall-mounted system with a video conferencing unit up on top, a flat screen TV here, and that'll move up and out. All they have to do is hit one power button, give us a page, and the docs on our end will hook up, can call in, and be part of, be there virtually during the consultation. We even have these at our homes, and I've done this several times from, if my partner's busy inside the hospital in the ICU, or we are 24/7, then they'll give us a call and I can do this from home. Or I've done it a couple of times from my laptop, but that's with the video camera and the picture kind of sucks. There's another picture. And then there's these commercially available ones. These are our home-built ones that are mobile, can be wireless, of course. This is one in Australia where they make them look like, this is again pediatrics, they make them look really cool and the kids really love these. It's basically the same thing with the plastic case around these robots. So this is a disturbing video. This is a child that came into a small 2-bed emergency department at a hospital, and the kid had SIDS, or sudden infant death syndrome, so the baby was found down by the parents, pulseless, pretty much dead. But they're bringing in, there's a standard routine of care you try to do to resuscitate. This baby didn't survive, but it'll just show you what our doctors can do on our end to help out the remote docs.
Can you see the monitor now?
Wait a minute. Oh, it's at the head of the bed. Okay.
So that's our doc up there in the upper right. There's a monitor that she's looking at.
Okay, hold CPR.
Oh, crap. Did I do that?
PR for a minute.
Oh, good job. Hold CPR. You can see it's a flat line there.
Yeah. If you want to resume CPR, you can. This would not be a bad time to call the code.
And so this is where she was viewing that all from.
So
she just zoomed into the monitor up to the front and on the baby from afar.
About 10 minutes ago. And I said that not only did that her heart activity stopped, so.
I mean, depending on your comfort level, now wouldn't be a bad time to bring them in so they can see what's going on and can be with her when can be there when you say it's enough, and they can kind of hold her right away and stuff.
That's a great idea. The dad's been here through most of it, so
Okay,
I'll
good.
call them.
Okay.
Okay. Did you hear their suggestion?
So I'm going to, okay, that's it right there. But that just demonstrates, they see one of these every 2 years, and we unfortunately see it quite frequently. But there's a lot of stuff. It was very comforting. This hit the news, and they wrote letters because they were very appreciative that the family felt very good that everything that could have been done was done. And so even though it's a horrible thing, it was good from the doctor's standpoint. So this is another, I think that's fine. You have to keep getting up for this. This little baby.
The work of breathing.
Okay, this is a baby that they wanted to transport to us, and our doc in the upper left. And they wanted to intubate or put the child on a breathing machine and transport to our hospital.
2.5 liters, and then.
And this is, it's not cheap. It's the inexpensive way. I mean, we can of course, transmit monitor information and stuff like that, but we do it this lame way where we zoom the camera in up on the monitor and get the vitals this way. But anyways, our doc was able to see the child. The kid never got intubated or put on a breathing machine and was able to go home, and so I think that was a good outcome there for that child. Now, I have a lot of anecdotal stories, but I do try and do some science for all of you in the room where we're doing different measures of parent satisfaction, comparing it to telephone consultations and no consultations, and it's clearly higher. The parents are much happier with the care when this technology is used versus just the telephone, and they even think more highly of their local doctor also, because this is a little bit tangential, but some of the rural ED docs feel like, they don't want to call because they don't want the parents to get the impression that they don't know what they're doing. But we have data to actually say the opposite, that they're involving a subspecialist makes them seen as better doctors in the parents' eyes. We also we have a pretty well-structured scientific way of measuring quality of care that's provided to these children, and we found, this is unpublished data, but we're finding higher quality of care scores We spend more time with the patients. We have more recommendations on interventions compared to the telephone and no consultations. And it's difficult to measure, but we're investigating the efficiency of care when we do telemedicine. And I added this part, there's lots of ways to improve this model. One is hopefully, like I say, we will be connecting all of the emergency departments, or all of the hospitals at least in California, to the tertiary centers. And we don't have good ways, efficient ways of collecting all of the information. I told you how we're looking at zooming at monitors. Clearly there's better ways of doing it. Clearly I saw today, like better ways of visualizing people rather than just with the monitor that we're doing. Efficient ways to communicate recommendations and care. So there's a lot of improvements that can be made on this so far low-tech solution that we do, which is the basic video conferencing. So it also, I mentioned, this is just the one slide on inpatients, I think. But again, if somebody is hospitalized where they don't have that subspecialist, hopefully there will be the day that it's no longer an excuse that, oh, well, we don't have that type of a doctor here, because that doctor can be there. And there's actually been a couple court cases, and court cases always, like, doctors sit up when you say that. But it's actually gone the other way. People are like, oh my God, I'm going to get sued if I do all of this, but we get sued anyways, pretty much. And because I swear to God, when I get a telephone call, it's always like, hi, how do you spell your name? Because they're writing it in the chart, and so we're involved with it anyways. But there's been a couple bad outcomes on patients nationally where we didn't have a neuroradiologist to read this CAT scan, and the patient ended up dying. And it's like, and then they brought it up to try and sue that hospital. It's like, well, there's this technology out here, and you didn't have that technology, and that could have saved this patient's life. None of them have gone to court, but in the future, these are going to come to court. And again, this whole model of care where specialists can see patients anywhere, I think, will increase the quality, reduce medical errors, obviate transports, and I'm trying to do that. See, I was wrong. Telecardiology is a low-lying fruit, and I'm going to just show again. This is the way that we do it. We have this echo reading room with all of it on the PAC system, or DICOM. See, I don't know all of the technology, computer. This is our pediatric cardiologist's daughter's playroom, but that's also where she does consultations a lot from home, and she has a video conferencing unit. So she's reading echoes and seeing patients, counseling parents at 5 different sites over Northern California from her home. This is another little show and tell. So what we're doing on a patient that would totally have been transported from Mercy, from Southern California. So it would have been transported from Northern Reading to our hospital had it been not for this technology.
Okay, I'm not going to be able to see if everybody's clear.
So this is a baby who has supraventricular tachycardia, SVT, and the baby gets a little shocked.
Let's charge it 2 joules.
Watch the baby.
Whenever you're ready.
Bink. So that didn't hurt him. It's only it's only 2 joules, and boom, there's our cardiologist.
Like
that's the one with the 7 playroom. She's able to see that she converted the baby over to normal sinus rhythm, and it was all from our mobile unit way back here.
See
that's
breathing?
The neonatologist over there on the left with his hands in the pocket. And she's able to look how the baby's breathing. Clearly fast, but that's not unexpected and the baby was managed there and never had to be transported to Sacramento. Not that Sacramento is a bad place.
Well, that was interesting.
Yes, it's sort of a...
But it costs $12 to park there a day. So we also do telemedicine in the intensive care unit. Again, this is what I do, so it may not be the biggest application of telemedicine, but... So again, I mentioned the one north of us is Portland, Oregon. There's 1,500 doctors in the country that are trained in when I am, and there's a huge shortage. And the same thing for adult critical care physicians. If anybody knows anything about like the leapfrog or healthcare, the status of healthcare, there's a huge shortage of intensive care unit doctors, and it's a problem because there's lots of studies that have shown that, whatever, I guess we like this data, so we fudge the data as much as possible. But our care has been associated with reduced mortality, reduced length of stay, and hospital costs. But there's a shortage of these docs. How are we going to do this? And there's a couple models of care where there's remote continuous monitoring of several ICUs from a station. So a doc and 2 nurses are in this control room with probably 40 monitors, and they can be watching 5 different ICUs at one time. They can round on the patients. They have smart alarms, and it's a very efficient but very expensive way of monitoring these patients in remote intensive care units. And then what I do, again, not the cheap but the inexpensive thing, is where if there's kids that are admitted to adult intensive care units, not infrequently, and if they need my help, they can just call and I can hook up from my ICU or from my home, or one of my partners can. So we have this, and see, it's all just show and tell. There's no data here, but that's okay. I should have put at least a p-value or a blot or something like that.
And I would dial the pressure.
So this is a kid, an adolescent that was admitted to, I shouldn't say, to a ICU.
Maybe give her a tidal volume of
and
about,
she's dying, really, but the doc is across town because there's 2 hospitals, and that's just the way it is very commonly provided here in the United States, even though we don't like to think so. I mean, you guys are in a big metropolitan area with lots of ICUs around, but there's a lot of places where sick adults and children go where there's just not adequate coverage. So again, the inexpensive way of getting like vital sign information here, the kid's blood pressure is 93 over 33, very tachycardic. Our doc here is able to assess a chest rise, which is a very important thing in looking at the breathing machine. Again, the doc's not there. Something called capillary refill that we look at, and I don't know if you can tell, but if you push on your foot and take your finger off, it should turn red pretty quickly. The fact that that doesn't turn red is very, very bad, very poor cardiac output.
Yeah, I would start the
67 over 26, that's not a survivable blood pressure for very long.
Okay.
And our doc is still hypotensive.
Sorry, guys. How's everything going?
Okay, we got the NG tube in.
Sepsis, just an infection in the blood, otherwise healthy child. And in,
Hey guys, David Consul, I'm here
If-
now. Sorry, I was across town.
Who's that? Hey, Dr. Chuck.
walked out of the hospital, did fine, but the way that the hospitals are run in these smaller towns, I don't know if that girl would have survived otherwise. And it's the same with adults, too, if you don't have access to immediate access to the people that know what they're doing. So again, we have done, again, trying to do scientific studies on this stuff, and we've been able to show comparing pre and post and kids that don't get telemedicine consultations. Clearly, they consult us on younger children, sicker children, when there are higher rates of mechanical ventilation or on the breathing machine. And we've been shown that those kids that have been taken care of remotely in the adult ICUs have gotten good quality of care. Their length of stay is all very good. There's been one child that died that received this, and that was a child that would have died otherwise as a child that was in the pool and drowned. And we think that we did a big service by having the child die in a local community with family and support systems, because 9 times out of 10 what happens is they get transported to us, the family comes down, they're in a hotel paying $12 a day for parking, and their kid dies that way. And we also have very, very high rates of parent satisfaction. This is the one piece of data that I have up here. When we were asking the parents how they felt about having their child be cared for locally with this technology versus transport, and more than half of the parents ranked it as extremely important, versus the docs on their end, only 20%. And this is common for docs. They're like, transport. Like, just get them the hell out of here. It's less work for me. But we don't really appreciate the, what's a word? See, I didn't do good on the SAT for English. And whatever. So it's really not hard. It's hard on the parents to be put outside of their local community with their support staff. We've also been shown by, hey, this is the dollars and cents, but when they keep kids there, ICUs typically make money. It's very expensive. They call it the expensive care unit also. But they make a lot of money. So we've been able to show that with them keeping kids there that would have otherwise been shipped to us results in a lot of revenue that they generate. So they're willing to pay for us to be available for them 24/7. So good for patients, good for parents, good for that hospital, and and good for us. And we were taking over because they used to go send it to our competition across the street. So we do a lot better with it's a marketing tool. Child abuse, again, these are like my things that I do, so I'm sorry you have to hear it. Child abuse is much higher in rural counties. The darker the color here, the higher the rates of child abuse. We've had a pilot project going on, and we just got a 3-year grant from HRSA, MCH Maternal and Child Health, to what we do is our child abuse experts are able to help examiners in remote areas collect appropriate evidence for children that have been physically or sexually abused. Typically what happens is they'll do not such a good job with the data collection or the evidence collection, or they'll ship them to us and put some kid in a van with the sheriff for 4 hours to drive to UC Davis for their exam. And I think you can see this is like, so this is one of our nurse practitioners doing a live consultation showing what to do.
Place your hands just below the crease between the buttocks and the thigh. So you're going to place your hands kind of below there.
Had to get a good exam on whether or not this kid was sexually abused.
And actually go ahead and lift up, and that should get the pelvic floor to relax, and you'll be able to
and so it just very educational. And what's happening is now there's higher rates of reporting your child abuse. And it isn't because child abuse is more common, it's because they're looking at it now, whereas before they didn't. And there's, again, anecdotal cases of one example is when our doc was concerned about child abuse, but the doc on the remote end knew the family, and they're going to send him home, and he's like, hey, transport him to us. And he actually, after the video conference, called him on the phone. He said, I'm concerned about child abuse. And it turned out that the kid had subdural hematomas and was being beaten up at home. So it was able to intervene that way. Another example is like with the child abuse, when our people are watching and they're collecting evidence, and they're on a girl, they were done, and they go, and our examiner was like, the girl said that a guy was like licking her ear, so they swabbed it and got DNA from the ear, and they were able to get the perpetrator with that piece of evidence that they would have otherwise missed. We also use this technology to help, I know it's gross, isn't it? So help connect hospitalized children to their families and friends. This is a little, again, a silly show and tell video where a girl who was hit by a car in Weaverville, lost her legs, and the thing that she missed most were her friends at school.
Hi guys. How are you? Hi Nicole.
So at lunchtime,
how are you?
They set up a room where she could visit all her friends that night.
I miss your butt shaking.
This is over this is what we call POTS, or plain old telephone service. So this is cool. Just over telephone. Clearly this can be done better with broadband and things like that. Now we have 2 lines, right? 1 line for the video, 1 line for the audio. But this, oh my God, she was...
Yeah, I want to see Brian.
The nurses hated taking care of her. And in this, transformed her, and so it was like she was a much more pleasant person. As you can imagine, she was in the hospital for 3 months. Ravi knows about this. Another type of application is for video interpreting, so lots of patients that speak different languages. I'm sure you have that here. But rather than the interpreter traveling all over, we have now, our interpreters can sit like us in the cubicle in front of a computer and do translations for all of our clinics and our satellite clinics that we have around the Sacramento area without having to drive to these areas. And there's data to show that it's much better. It's not as good as a person being in there, but you miss a lot of the, what's the lingo? Gosh, that you guys were telling me about the interaction, nonverbal communication. See, it's like I won't tell you my SAT score in English, but see, you can still be a doctor. So it increases efficiency and improved parent satisfaction. So we've been able to do that, and there's businesses popping out now with banks of interpreters that are trying to provide this to hospitals nationally, 24/7. Okay, I have a couple. This is all total show and tell, or do you want me to stop? Are you tired of show and tell? What are you gonna? This is Dr. Muhammad Ali, and that's his real name.
My name is Dr. Muhammad Ali. I'm
the Director of Minimally Invasive Surgery here at UC Davis Medical Center. And today we're performing a gastric bypass laparoscopically with the assistance of the Zeus robotic surgical system. This system allows me to sit at this console, and with my heads-up display I can see the laparoscopic view, and these controllers that are in my hands allow me to allow the robot to emulate my hand movements to the movements of the instruments that are inserted within the laparoscopic ports, so that it's really quite extraordinary.
So he's sitting across the room in that chair, and that's the patient he's doing surgery
because
on.
of the increased number of degrees of freedom. But suffice it to say that the camera robot actually moves depending on my voice commands. For instance, if I ask it to move right, it moves right. If I ask it to move left, it moves left. So what I do is I call on it. So I say, stop, move left, and it moves left. Stop, move right, stop, quit. And so it really, the technology that has been developed in robotics for surgery has really been enabling for us to do our jobs better, to do our jobs more efficiently, and I think to get better outcomes for our patients.
So he's done, I think, more than 1,000 of these, and this is the way he does it. And the reason that, so why wouldn't he want to, or another surgeon to do this in person? And the one weird thing about laparoscopic surgery is that they put in these long bars, right? So to move the instrument up, you move it down, right? Because the fulcrum, or that's a big word, where you turn it like is there. So it's been shown, like, if you're going to do heart surgery and you're open, it's better to do it with your hands. But laparoscopic surgery takes a long time to learn, and it's also, everything is magnified. I sat there and they go, oh, pick up this needle, put it through a loop, and you're like on the robot, and they go, now go look what you did. And it's a very, very tiny needle, and it's remarkably, it's enabling for the surgeon to be able to do a lot more that way. And it can be done over distance, as you can imagine. Right now he's just across the room, but it has been done transatlantic this way, and there are programs in Canada that actually do surgery this, where the surgeon is in one city, there's a backup surgeon, and there's nurses, everything at the other city, but he does surgeries in several cities using this technology. You need backup bandwidth and all of it. Clearly that's the big issue here. This is an
Okay, so R2-D2 wasn't this clunky, but maybe it's a good idea nurses can hear this robot coming a mile away.
So this is a doc. Now we can just stay at home and see our patients remotely.
To drive, and judging from
or from the golf course. I'm just joking. I don't golf.
Everyone thinks it's pretty cool.
I think it's terrific.
Imagine Larry Whedon's surprise when he woke up from surgery and found himself talking to this guy.
Good afternoon. This showed up and was sort of unintrusive, you know, and spoke my name and woke me up.
You're looking well.
So there's my doctor.
Okay, whatever. He had this funny line where they go, don't you find it impersonal? He goes, since when are doctors personable in person? So I think this is the last slide. Again, I'm biased or whatever. Telemedicine will transform the way that we currently practice medicine, deliver health care in a lot of different arenas. We hope to better address disparities in access to care, disparities in quality. There's new devices clearly to remotely monitor patients in hospitals or at home. You're developing some of those technologies here, which will be a huge application. But there's lots of investigation that needs to be done on what models are cost-effective and efficiently used given our limited resources, including cash and specialists. And that's kind of like Ravi wanted me to mention this. There's several studies that we have going on with telemedicine and these applications at UC Davis where it could be considered a test bed because we're really trying to measure the impact of this technology on health outcomes, satisfaction, medical errors, and costs. So it's an opportunity to advance the science as well as know where it works and where it doesn't. Thank you.
Great presentation. You went up, Dave.
Thanks, Tom. Actually, my background's in material science, but this is what I wanted to ask you. In recent times, we've had a tremendous amount of progress in all kinds of sensors, integrated platforms, that kind of thing. And I see a day in the future, not too long from now, where you're going to have home diagnostics, kind of like a smart doctor thing you have at your home. And virtually most of medicine is, well, we're going to be from the home via some kind of Web 2 connection or something like that. Do you see this future? Or how do you?
Yes, I totally do. I think that we're there now for in-hospital monitoring. Like a lot of these patients are left in just with some nurses and simple monitors. Now we're having these dock-in-a-box monitoring much more closely, a lot more features that they weren't doing before. And absolutely there's an application at home. And I'll tell you, I think there's been lots of studies to show that use of this technology at home reduces emergency department admissions, reduces mortality, but whatever, this is my biased view, or in my opinion, a lot of that it hasn't blown up as much as it could because of reimbursement. CMS, Medicare and Medicaid says, that's cool, good job, keep up the good work. They haven't been paying for it. Why the hell should they pay for it? So but hopefully there's legislation in Congress right now, but to be able to reimburse for it because it's cost effective.
I was hoping that you might add some thoughts about maybe, as people buy health insurance, maybe this would become like a layer in the insurance process, and therefore there'd be reimbursement and everybody would be satisfied. I was kind of thinking that would be possibly the model.
That's, yeah, if you can afford it with health insurance, then that would be a possible model. Again, it's hard because I think if it's cost effective, then you shouldn't have to pay extra for it. But it's one of these technologies that people just don't want to pay for it. Because insurance companies know patients that live in rural communities, they don't use specialty access. So it's cheaper for them to have worse outcomes. And no, seriously, they admit this. And not have to pay for the increased access. So who's going to pay for it? The federal government, or so those issues have to be addressed.
Just so UC Davis Medical School is a research teaching hospital. A little bit about what the research agenda is in telemedicine. Is it just gathering information about its effectiveness and its cost reduction, or are there other aspects to the research agenda that you could talk a little bit about?
That's a very good question. It's a lot of us just use it as a clinical tool. So the psychiatrists will have full-day clinics in telepsychiatry, and there's probably a lot of, we don't take advantage of the potential opportunity to study the impact on health outcomes and the financial part of it. But I think that unfortunately it's like a lot of the doctors there are they're there to provide health care because that's where their salary comes for and that's what generates the income. And so I think that there's probably a lot of lost opportunity. But I think that with what I know as the pediatric person, a lot of it has to do with the impact on health outcomes and the financial part. I'm not sure if you had other outcomes that you're thinking about in mind, Rob.
Yeah, in fact, there's a lot of interest, and many of the faculty who are interested in telemedicine are represented here in what you could do. What are the limitations today that if engineers and scientists were involved, you could solve? So one of the things that many people see here is that telemedicine gives you something that you couldn't typically have before, which is presence. And by having presence in the field, you decouple diagnosis and treatment. You do diagnosis in UC Davis, and you allow people on the other end to actually carry out the treatment under advice.
Right.
So what is limiting that to go even further? Are there instrumentation problems? Are there presence problems? Is there anything else there that maybe something else could happen? So that's sort of one of the
Well,
issues
that's a very good question. I wish I knew a good answer to that. I think that a lot of the business models, because the docs they say they're very busy. So why do I want to see patients now remotely? Because I'm already busy with the patients here. And how long does it take you to see your orthopedic after a referral? A long time. So I think a big thing limiting the growth of this is the efficiencies of data gathering, communication. So us faxing notes and things like that. It's just all so like 1990s. That there's a lot of improvements that can be done on that end. And I apologize. My end of the world is more towards. There's lots of hospitals that don't have access to us. And there's progress being made. It's like, hey, we can do better telepresence with visualization and things like that. And my world is more like there's people that don't have access to basic good doctoring. And so I know less of the world on the cutting edge technology, which is where a lot of your worlds are, so I apologize for my bias.
Yeah, I was wondering in the liability area, which is a bit of a concern, but you mentioned that there was there are cases where with telepresence there's a potential conflict because there isn't the local specialist that maybe they should have. But is there some point where it flips and the care center is expected to have telepresence to deal with cases that they can't treat locally? I mean, when does this technology become part of the a standard suite of technologies so that I guess there'll be pressure the other way?
Right. I think when there's money so if something is reimbursable, doctors will do it, because if they can get money for it. And the other thing is legislation. So telestroke is a very good example of this. We could say, if I can see your stroke patients earlier with a neurologist, I can improve their outcome. Everyone's like, yeah. And what happens is there's data that comes out that says, hey, with this remote monitoring, having access to a neurologist and a neuroradiologist improves the outcomes and survivability of these stroke patients. Still, everyone's going like, yeah. So what? It costs money. Then states and counties start enacting legislation. If you want that ambulance to stop by your hospital with a patient with a stroke, you have to have this. You either have to have those doctors available or this remote presence available. Boom. Florida is filled with it. Massachusetts is filled with it. California, it's still left up to at the county level. So it's, where doctors will go or whatever, where the money is, and health insurance will go where the money is, and whether it's kind of forcefully enacted as a low bar for level of care by legislation. Does that answer your question? I'm sorry.
Question in the back.
You said that psychiatry from the general practitioner's office is one of the big three in telemedicine. It seemed that doing psychiatry from home via telemedicine would be such a simple thing to implement. DSL lines are so cheap now. Is anything being done? Why hasn't that moved forward?
Why? Because the doctor doesn't get paid for it. The psychiatrist won't get paid for it if they do it from home, but there's legislation that's coming from home. The opposite is happening. I know dermatologists that do patient care from their homes, hooking up to different clinics. But until there's reimbursement to the doctor so that they can provide that medical consultation at a patient's home, it probably won't happen, right?
Okay. Last question.
So you explained a lot about why it would be beneficial for the rural centers to put in the hardware needed to actually carry out telemedicine. But you also mentioned the fact that the specialists in urban centers already have plenty of cases to fill their time. So what is the actual incentive for the specialists in the urban centers to do their part of it?
Money. I mean, we want to expand our base. Our telecardiology program, right now, they provide those consultations 24/7 to that hospital for free. Why? Because if there's a kid with congenital heart disease now at those hospitals, they come to our heart center and not the competition's. And when a kid comes with congenital heart surgery to our hospital makes a profit. So if there's competitions between, I think one of the big reasons that UC Davis is the leader in telemedicine is because there's a Mercy healthcare system, there's Kaiser, there's Sutter, and it's very competitive. And this is a way that we could grow our market share, increase the number of physicians that we have, get more patients this way. It's a business too.
All right. Please thank our guest, Jim Marson from UC Davis. Thank you, Jim.